Hello, my name is Hedda Nilsen, and I'm a specialist in pathology and psychiatry, and I am the leader of the Department of Mental Health and Addiction Medicine at Nordland Hospital Trust. Nordland Hospital Trust is located in Bodø, a city just above the Arctic Circle in Nordland County, northern Norway. I'm very pleased to share some of our research findings from my PhD project at the Arctic University of Norway. I have a special interest in the field of biological psychiatry and biomarkers. This is a picture from the main part of our hospital for mental health. The hospital was built in 1896 and is one of the oldest asylums in Norway. We now have an inpatient capacity of 140 beds. We have a local mental health service for the population in Nordland County, as highlighted here in the light blue area. We also have regional services for the whole area of Northern Norway. Northern Norway covers an area of approximately 113,000 square kilometers, and Bodø is the second largest city in Northern Norway. I am pleased to be given the opportunity to present our latest article published in BMC Psychiatry. This study was funded in part by a grant from Northern Norway Regional Health Authority. All authors declared no conflict of interest with respect to their authorship or publication of this article, and the study is approved by the Regional Ethics Committee. Identifying the causative and maintaining role of biochemical factors in mental illness may aid in the development of more effective and personalized treatment and also prevention of mental illness. Brain-derived neurotropic factor, BDNF, plays a protective role in the brain, regulating neuronal activity and promoting synaptic plasticity. It also modulates synthesis, metabolism, and release of neurotransmitters, and it is suggested as a biomarker in mental disorders. Its peripheral serum levels strongly correlates with brain levels. In most previous studies, serum BDNF correlates negatively with psychiatric disorders and also disease severity. C-reactive protein is a well-known marker of systemic inflammation. High-sensitive CRP is used as a biomarker in this project since it is a more sensitive test for low-grade systemic inflammation. CRP is synthesized in the liver in response to certain pro-inflammatory cytokines. The aim of this study is to explore if there are any associations between BDNF and high-sensitive CRP with general psychiatric symptoms, independent of diagnostic groups. Comparison between the group regularly using psychotropic medication and those not using psychotropic medication is also conducted. It is a naturalistic study, so patients were not randomized to either medication or non-medication group at referral. Patients included in this study were aged 18 years and above, and they were all able to give informed consent. They also understood Norwegian language, and I included patients over a 4-year period from the area of Nordland County. Patients to this open inpatient ward were referred from outpatient services and from general practitioners in the area. A total of 132 patients were recruited when we eliminated those with incomplete datasets. All data were assessed by me upon consultation approximately 1 week after admittance to the ward. Weight, height, and smoking habits were obtained from all patients. Age and gender were obtained from person identification data. At assessment, a rating scale for psychiatric symptoms was administered. Symptoms were measured by symptom checklist with 90 items, SCL90, and grouped as 9 symptom clusters, which are the following: depression, somatization, obsessive-compulsive, interpersonal sensitivity, anxiety, anger hostility, phobic anxiety, paranoid ideation, and global severity index. By using SCL90, we were monitoring the actual symptoms as experienced by the patient during the last week. It is rated on a 5-point scale from 0 to 4. Blood was withdrawn in the morning after fasting and rest and no exercise. The further biochemical measures were performed at the Department of Laboratory Medicine at Nordland Hospital Trust, and according to the instructions of the manufacturer and by a trained technician. Multiple linear regression analysis was performed using BDNF and high-sensitivie CRP as dependent variables. Symptom clusters as well as confounding factors as BMI, smoking, age, and gender were set as independent variables. The sample was split in 2 subgroups for those regularly using medication and those not using psychotropic medication. The characteristics of study participants showed a larger share of women and non-smokers. Also, 102 out of 132 patients were using medication. Our patients had the highest scores on depression, obsessive-compulsive, somatization, and anxiety symptom cluster. Age ranged from 18 to 78 years and with a mean of 37 years. Serum BDNF levels spanned from approximately 13,000 to 50,000 and with a mean of 27,000. High-sensitive CRP levels spanned from 0 to 35 and with a mean of 2.7 and a median of 1.6. Fourteen out of the 102 patients using regular psychotropic medication used a combination of either antidepressive medication and benzodiazepines or antidepressive medication and antipsychotic medication. So, 8 patients used a combination of antidepressive medication and benzodiazepines, and 6 patients used a combination of antidepressive and antipsychotic medication. Since this is an inpatient ward for patients with general psychiatric disorders, like depression and anxiety disorders, thus not a ward for psychotic disorders, we presume that the use of antipsychotics in this population is off-label use, for instance to improve sleep and reduce agitation. In the subgroup of patients not using psychotropic medication, we found a positive association between BDNF and most symptom clusters apart from the following three: paranoid ideation, anger hostility, and obsessive-compulsive. The results remain significant when adjusting for age, gender, smoking, and BMI, as seen in this slide. In the subgroup of patients using psychotropic medication, the paranoid ideation cluster was the only symptom cluster associated with BDNF. The association was also negative, adjusted for age, gender, smoking, and BMI, as shown in this slide. We did not find any association between high-sensitive CRP and the different symptom clusters in either group. Other studies have found that high-sensitive CRP is related to severity of depressive symptoms. Increased high-sensitive CRP has been reported in patients with fibromyalgia and chronic fatigue syndrome, as well as in depression and anxiety. We do now have a group of healthy controls and thus cannot claim that our patients actually have increased high-sensitive CRP. But a mean level of 2.7 represents moderately increased risk of cardiovascular disease. So we could not reproduce findings from other studies in our results regarding high-sensitive CRP. We found positive associations for most SCL90 symptom clusters with BDNF in the psychotropic medication-free group. We found association only to one symptom cluster, the paranoid ideation in the medication group. However, most previous studies report a negative association between mental suffering and level of BDNF. This negative association is reported to reverse with successful treatment. Some studies did not find any effect of medication on BDNF levels. So far there are inconsistent findings in the literature. One explanation to our result may be that the body and brain conduct self-repair and compensates by upregulating BDNF in the group not taking medication. The group of patients taking medication did not show the same upregulation despite the same symptom burden as reported by SCL90. The main limitations of this study are as follows. Using self-report questionnaire is always with a risk of biased reporting. It is a relatively small sample size, especially regarding the subgroup of patients not using medication. We did not study BDNF in relation to diagnosis or symptoms compared to a healthy control group, and this might be the main limitation. But we are still able to compare mental suffering with BDNF and high-sensitive CRP, adjusting for the main confounding factors. We also did not use psychiatric diagnostic groups. Thus, we cannot relate findings to other studies based on diagnostic groups. One main originality of our study is the focus on symptoms rather than diagnostic groups. As the psychiatric diagnostic groups are merely syndromal, with collections of symptoms or signs often seen together, they may not represent one common biological process. Diagnostic groups are also wide and partly unspecific, masking differences within the groups. Another original factor is that data were sampled roughly 1 week after admittance to reduce potential stress achieved by the admittance itself for the patients, and thereby to reduce any possible stress-induced alterations in the biomarkers. We used known confounders, and biological measures were sampled in the morning to avoid effects of diurnal variation, as especially serum BDNF have been shown to have such variations. The laboratory used standardized protocol for analysis and with one experienced technician. And I did all the assessment of every patient myself. Our results provide further evidence for a role of BDNF in the pathophysiology of mental disorders, especially revealed in the group of patients not using psychotropic medication. Patients on psychotropic medication may not require the same upregulation of BDNF because medication is modulating the underlying biological pathology. Furthermore, it also suggests that BDNF alteration in general mental disorder reflect response to general stress and mental illness, independent on presented symptoms. High-sensitive CRP is not specific for any symptom cluster, but rather related to mental suffering and also cardiovascular risk in a general psychiatric population. The people that I wish to thank for their invaluable contribution are shown in this slide. I would like to end this presentation by showing pictures of the Arctic midnight, with the northern light in winter and the midnight sun in summertime. So thank you very much for listening, and thank you for this opportunity to present our results. Thank you very much.